The following is part 3 of a 5-part series wherein the medical intervention gender-affirming surgery is discussed from a clinical perspective. The featured physicians each have decades of medical experience with an intimate knowledge of both medicine and the medical industry. In this third video, there will be an in-depth look at the male-to-female surgical procedures and their potential complications. The intention of this series is to take an objective, scientific look at these intersex operations. As such, the content at times will be explicit, and the viewer should take precaution and use discretion when viewing.
Welcome to the Gold Report, where we inspire you to be 10% more courageous. I'm so glad you're here. Please share, like, and subscribe so you never miss an episode. Today, we have Dr. Melanie Crites-Bachert back for part 3 of our 5-part series on medical mutilation. And we'll be right back to welcome her to the show. Gold Care is the replacement for the current healthcare system. How does it work? First, you join our Gold Care Association, which keeps the government out of your business. Then you can schedule with a provider of your choice and meet through our proprietary telehealth platform. We work to get you well and off of prescription medication. All costs are upfront and transparent, as it should be. Do something for yourself and your family, and put a doctor in your pocket. We are ready for you. Our show today is the third in a 5-part series on medical mutilation, often referred to as gender reassignment surgery. Our series is aimed at informing the public specifically regarding children. The race to mutilate children under the guise of normalizing it, a so-called medical or therapeutic option, must be exposed for the fraud and harm that it is. Doctors cannot participate in a social movement that harms patients.
Dr. Olson had a decision.
You are in the perfect place to start on blockers.
Josie received the blockers as an implant in her arm.
It's okay if you cry.
So with all the bravery she could muster,
Now you're going to feel a little bit of a...
Josie held on tight.
Ow!
That terrifies me.
It's all done. Do you want a hug?
I don't know that she would have survived male puberty.
Hospitals and doctors that are making a fortune of money off harming young people must be exposed. There is no one more qualified to speak on this topic than our guest, Dr. Melanie Crites-Bachert. She received her medical degree from the West Virginia School of Osteopathic Medicine in 2003 and completed her residency in urological surgery at the University of Medicine and Dentistry in New Jersey in 2009. She then received fellowship training to specialize in female pelvic medicine, voiding dysfunction, and pelvic reconstructive surgery from the Cleveland Clinic in Florida. Dr. Crites-Bachert is considered an expert at treating urinary and fecal incontinence with sacral neuromodulation and has a higher than national average success rate of 93%. She became a nationally recognized consultant and proctor for sacral neuromodulation therapy as a result. Her research and implant protocol is patent pending and has established national precedent for the successful implantation of a sacral neuromodulator. Additionally, Dr. Crites-Bachert is highly trained and skilled at performing pelvic organ prolapse surgery with and without mesh, and she's very skilled at surgically treating complications from previous mesh surgeries. She maintained an active role in research and tracked her own personal outcomes with pelvic reconstructive procedures. She has published long-term data results from her own patient population for treating urinary incontinence and pelvic organ prolapse as a private practice surgeon. We want to emphasize that although Dr. Crites-Bachert is highly qualified, she has chosen not to perform medical mutilation procedures. She has turned down lucrative opportunities to perform medical mutilation procedures. There are many voices currently speaking about this topic from different perspectives. There are certainly resources available that weigh the pros and cons. The focus of our series is to provide the necessary medical information about these procedures, information that is completely absent in public discourse, and we will be exposing the brutal physical reality of medical mutilation. Thank you so much for joining us, Dr. Crites-Bachert.
Thank you. It's a pleasure.
Thank you. So we're doing part 3 of our 5-part series today. And today we're going to talk about male-female medical mutilation. And I guess that we'd like to start in the beginning, which is what steps have to have taken place before a person shows up in a urological surgeon's office? What steps would that individual have had to take before they end up in your office?
So typically, the new established guidelines, as we've talked before, this is in its infancy, but the newly established guidelines are that the patient has to live in that particular gender role for at least a year. They have to go through hormonal therapy for at least a year. They have to have some sort of psychological care and whatever mental health issues that are present, or if not, needs to be addressed first. They also have to have 2 to 3 letters of recommendation from a provider recommending them for this gender reassignment surgery, as it's called.
So to just we had talked about that Matt Walsh episode that we saw.
In case you missed it the other day, after a 22-minute video call, just 22 minutes, Plume approved one of my producers for an orchiectomy, which means testicle removal.
You know, in that episode, we saw a health provider approve somebody for genital surgery, really based on a 20-minute telehealth consult where they didn't even seem to meet any of those past criteria. How does something like that happen? Do you have any?
My personal opinion of that is irresponsible medicine.
Yeah.
Because that absolutely should not happen. You should not have a blanket rubber stamp, especially when somebody has said they don't have gender dysphoria,
Right.
which was actually reported.
Yeah.
His undercover operative didn't use the buzzwords, didn't say he has been living as the other gender, identifying as the other gender, which is labeled as gender dysphoria. Didn't use any of those buzzwords.
Right. So before we go on to the next questions, I want to explain to the audience why we're even, doing this episode. Actually, obviously, Dr. Crites-Bachert is a surgical specialist really in this kind of area. So her expertise informing us as to what the medical treatment is actually invaluable. I come to this as an emergency physician, but when I was in medical school, I had the unique experience of working with transgender patients. I say unique because it was very, very uncommon. Mm-hmm. Just kind of the way it worked out, looking back on my life, maybe it was destined. But I did take a course in transgender treatment, and I think it's informed why I am so upset about what I see. So back then, in the 80s and in the 90s, first of all, this isn't a brand new situation. Like, doctors have dealt with this for decades, and we're acting as though this is a brand new problem. It's not. We had a way to treat it. And there was a protocol back, in the 80s and 90s that I was part of implementing, I should say. I was working at Cook County Hospital, which is one of the largest county hospitals in the nation, the largest county hospital, of course, in Chicago, probably in the whole Midwest, I would say. Very, very busy. And we had a transgender program. And before you could even think of seeing a surgeon, you had to do the following steps. You had to be enrolled in the program essentially for years. You had to undergo individual psychotherapy. You had to do group psychotherapy. You had to live as the opposite gender for many months. You had to, of course, have a complete physical checkup. After you lived as the opposite gender for at least 6 months, you had to prove that you had done that. You had to change your driver's license. You had to change your status with your employer. You had to show proof of that. Your employer would have to write a letter to the program and say that, Sue was now Bob and showing up to work as Bob. You had to dress, you had to show proof of the dress, and you just had to show absolute proof of this. Once you did all that for at least 6 months, you were then eligible for hormone treatment. Once and you had to have, at that point, you had to have 1 or 2, I forget, psychotherapists approve of this. After you had done that, so now at least 1 or 2 years have gone by, then after 2 full years of treatment like that, you were then eligible for surgical treatment. Mm-hmm. And anything less than that amount of pre-surgical care was considered morally inappropriate, financially wasn't going to be paid for, and absolutely repugnant. Mm-hmm. And we've gotten to a place now where a telehealth consult for 20 minutes on the phone replaced all that. And I just wanted to share with you that I've seen those protocols. I was part of those protocols, and you had to have all of the steps done before they'd show up to you.
Mhm.
Right. I mean, I guess there is nothing to say about that. I mean, we're now in a diametrically opposite situation
Correct.
than we were years ago. We have these parameters or protocols, I guess, in place because as you're about to go through, the repercussions of going down the road of surgery are permanent and severe.
Mhm.
So, of course, before you choose a permanent, severe option, you have to be sure it's the right path.
Mhm.
So, assuming you had the right pre-surgery treatment that we've talked about, hopefully you've had the therapy, you've had consults with more than 2 people, people who are experienced in this, people who've, you've lived as the opposite gender for a couple of years. By the way, the data that I read showed that if you had lived as the opposite gender for a couple of years, your success rate was much higher. So this precludes, in my opinion, children,
Mhm.
right? Because they haven't had the
Absolutely.
life experience of living as the opposite gender for years. But assuming they've had the best possible pre-surgical chances, an appropriate person shows up in your office for the surgery. What is the most common type of surgery, male, female genital surgery what typically happens?
So it's called penile inversion. So basically, you take the penis and the scrotum and you basically turn them inside out, kind of like if you think of a tube sock and you take the toe and you turn it inside out. So basically, you take the penis and the scrotum and you push it inside the body and fashion it such that when you push it inside the body, it forms a functional vagina.
Okay. So when somebody is thinking about having this procedure, before we get to that actual procedure, is it even a concern or on people's radar screen about any surgical complications other than around the genital region? Are there any concerns other than the genital when you're just doing the genital surgery from male to female, or is it only genital area? I know for you explained from female to male, you would have to take essentially a transplant.
Sure. So in some instances, if there's not enough penile or scrotal tissue to form a functional vaginal cavity, you would take flaps, from different areas of the body. Thigh would be one area, other tissue around the groin. So there certainly could be site graft harvest complications.
So when patients undergo this kind of procedure, can you just walk us through in a general way, what are the things that could go wrong? Looking at it from the patient's perspective, the patient is coming to the surgeon in the hopes of having functional female anatomy.
Mhm.
And that includes sexual satisfaction.
Mhm.
So just if you can walk us through what could possibly go wrong or right, however you want
Sure.
to.
There are a number of different things, such as vaginal stenosis, which is a narrowing of the newly formed vaginal cavity. There are things like a misdirected urine stream, which, by the way, shows upwards of 30 to 40% complication rate. There is a complication rate, of course, of pain. You're looking at sexual satisfaction. If we're specifically talking about sexual satisfaction, the head of the penis becomes the functional clitoris. There's obviously a risk of that necrosing, meaning dying off, and not having that sexual pleasure.
Do you have what are the most recent statistics on sexual pleasure? Because when I think of this as a physician, a general physician, not a specialist, whenever there's a part of the body where you have to move and do something else with it, so I've been familiar with on the hands or on the feet, you have to bring you have to bring the blood supply with it.
Correct.
And if you don't bring the blood supply, or you do and something happens, things happen, right? And the blood supply kind of dies off, all the tissue further downstream from that dies off. So
Correct.
what you're describing is you're bringing the penis, and the glands, which is the most sensitivity, bringing it up to make it into a clitoris. It has to have the blood supply.
Correct.
So that sounds risky to me. Okay.
It certainly is, and it's nice that you mentioned the most recent studies, because there actually is a study from the Journal of Sexual Medicine from 1 year ago, from February of 2023, looking at a cohort from Amsterdam, showing complication rate from a transgender situation, from male to female transgender situation, and it shows a greater than 75% failure to orgasm. So greater than 75% chance of not being able to have any sort of sexual pleasure, 75% loss of libido, they quote in this study. They also quote a 71% chance of pain during intercourse. A complication rate of vaginoplasty, which is the act of creating the newly formed vaginal cavity, an overall complication rate of that of almost 33%. A misdirected urine stream, meaning not being able to sit and urinate as a female. Urethral stricture, which is a narrowing of the urethra, the tube that carries urine from the inside, from the bladder to the outside of the body, has almost a 15% chance of complication, and certainly upwards of 30% of needing a repeat surgery. So this is one of the most recent studies that we have. So this is just from a year ago, from a cohort in Amsterdam.
I have to say, just sitting here listening to this as a female, I don't believe any healthy person would, especially a teenage boy, would knowingly give up the ability to enjoy sex to orgasm for anything, for a body that is a 75% chance that you can't enjoy sex. And you're telling me that there's, or the world is telling us that there's a whole bunch of teenage boys out there that really want to do this. I don't believe they've been informed. Nor do I think that even if you were told this casually in a conversation, that a 16-year-old could possibly make the life decision to take on the burden of no sexual satisfaction for the rest of their life.
Adult men have a difficult time making this decision. Right. I can't tell you the number of times that I see adult men with prostate cancer that don't want to have the prostate removed because of the risk of loss of sexual function.
That's a really good comparison. It is true. People who are facing prostate surgery are very slow to make the decision because it's a really complicated decision.
Absolutely.
And those are men with decades of experience.
Absolutely.
Of what it means. That by itself, I think should, okay. So we are here talking to a urological surgeon about the medical risks of what I call medical mutilation. And today, and specifically, we're talking about male to female. And there's not only is there a high medical complication rate, when you move tissue from one area of the body to another area of the body, but just the amazing loss of sexual satisfaction that I simply don't believe people are being informed of this. Yeah. Okay. Wow. Again, I don't know how you can't compare this to female genital mutilation, which every agency across the world has said is horrific because it deprives, women of sexual satisfaction in their life. So they've basically outlawed it or scorned it. So I don't see any difference between this and female genital mutilation. Causing a person to live their entire life without sexual satisfaction is inhumane, but it is being offered to our young people right here in America for the low price. Oh, we'll get to the price in the next episode. We'll get to
it. It actually isn't such a low price.
Exactly. For the just the price of pain and suffering and lots of cash for the doctors and the hospitals. Fantastic. Okay. I think I saw that study and it said, correct me, I think it said this in the study, less than 8% of male to female transitioners report their overall sexual satisfaction level following surgery as very satisfied. Less than 8% are very satisfied with their sexual pleasure or function. Fantastic. Yeah. So anyway, we touched on this in part 2, the female to male. But do you think that this phrase that I've heard popping up lately, transition or die, or it's better to have an alive son than a dead daughter or vice versa. Do you think this implied choice between a live trans daughter or a dead son or vice versa is an adequate and accurate statement that should even be out there in the common parlance.
I don't. I think it's a very absolute statement, and there are so many things that go into this. If somebody is truly suicidal, as we've spoken before, the first step is addressing that person's mental health. So to make an absolute statement such as that, we are assuming that every person that genuinely desires a transgender state is suicidal. And we're not addressing mental health issues surrounding that, or even, family dysfunction, just general counseling therapy. We're not even talking about spiritual counseling, which I feel is just as important as addressing mental health. You have to address and get to know what that person's spirituality is as well, because as Americans, we all derive comfort from whatever our spiritual
faith system is.
Yeah.
So I will say that as a person who, again, I had the unique experience of being exposed to this a long time ago in medical school, and there was no language like this. We were working with adult transgender people who were absolutely very, very, very unhappy. I want to go on the record and say that this, again, the series is about children and protecting children, and it's not specifically intended to tell adults what to do. I do want adults to be informed. I want them to hear this kind of information and make an informed decision. For example, keeping in mind the guidelines which required you to live as the opposite gender for a few years so that you absolutely are sure that that's the direction you want to go. Those safeguards really seem to have been dismissed. So we're not here to tell adults what to do, but we are here to share with you that the language around this has really, really changed.
Correct.
It was just as much unhappiness for an adult in the 90s as it would be today, but they didn't threaten, society with, oh, this person might kill themselves. It wasn't that. The person had to have psychotherapy, they had to have counseling, et cetera, but it wasn't a comparison between life and death. There were a few people who did have, issues that would have precluded them consenting to procedure because they really were, in more towards the suicidal. But you can pick that up and you can address that. You shouldn't threaten every single family, every single parent, every single child
Correct.
with that. And also keep in mind that young people tend to be very dramatic with their emotions. It's part of, being human.
It's part of growing up.
Exactly. It's a completely normal part of humanity. And we're here to tell you that the medical effects of choosing life-changing surgery like this are being minimized.
Absolutely.
Flat out being minimized. Do these types of statements, well, I guess we're saying that these types of statements like, transition or die seem to be glossing over the severe medical side effects.
Absolutely. Because again, this is not like changing your hair color. So to say, do this or your kid's going to commit suicide, that's a very absolute, very dramatic statement. And that's almost treating that as a very trivial sort of situation. Let them have this surgery or your child is going to die.
Right.
And as a parent, certainly if you are a responsible parent and you love your child, you certainly don't want that to happen. So again, that is the environment that we are living in now, fear-mongering and using absolutes to drive a decision.
So that's why we're here. We're here to explain the medical side effects as responsible physicians, because we just feel like perhaps, physicians are not being quite as responsible as they ought to be with very serious medical issues. Mm-hmm. Are you familiar with, or do you think that there's adequate data yet on people who've gone through this process, who've expressed regret or suicide rates? Are you familiar with that data, or is that not your area?
That's frankly not my wheelhouse. Okay. But what I can tell you from older procedures, from what I do, it's unless very good records were kept from a time such as that, where there were a smaller number of individuals going through this type of surgery. Unless very good records were kept, we would never know that data. You can certainly do literature searches. You're probably going to find very little associated with that, or the numbers will be very small, which then in and of itself can skew the data because there's not a robust number of individuals to actually take a look at.
I have to go back and talk to you again, like as a surgeon, because the surgical options requirements, obviously your specialty is urology, which is genital, urinary, and pelvic reconstruction. So you wouldn't, for example, be the surgeon somebody would go to for what is called top surgery, removing the breast or breast implants, and of course the facial surgery. But could you just lay out in an organized way what surgeries a male to female might be facing over the next few years?
So obviously the initial surgery, so castration, removing the testicles, penile inversion surgery to redirect that, redirect the urine stream and to create a functional vaginal cavity. You can have bowel surgery if there's a development of rectal prolapse. You're certainly looking at top surgery, such as breast implants. You're looking at then the steps of perhaps facial surgery. And all of this could be taking place simultaneously. For instance, you could be undergoing breast surgery and a few facial reconstructive surgeries to minimize the number of times that you're undergoing general anesthesia. And that is also something to consider. General anesthesia, it's not just as simple as going to sleep, and there's no risks associated with that. Every single one of these surgeries requires general anesthesia. And that is, chemically making somebody go to sleep for sometimes an extended period of time. And that is not without its own risks. You have issues of general anesthesia that can go wrong with the heart and the lungs. The anesthesiologist monitors all of that, but you can have heart arrhythmias and issues with the lungs.
Blood clots,
and
if
blood
it's
clots,
a prolonged
absolutely.
surgery, infection, and all of those things. And of course, virtually all patients that do this are also undergoing hormone therapy.
Correct.
So you are so male to female, you're removing the testicles. Then hormonally, you have to take estrogen and progesterone. Right. Okay.
Yep.
And I guess it's lifelong.
Give that biological male female hormones to feminize their life and to feminize their body.
Right. Right. It's very complicated. Like this is not changing your hair color.
No, absolutely not.
Not changing hair color. So we appreciate your expertise. I think that you're the only person I can think of that is really giving this just medical information out into the public. So we thank you for sharing your knowledge. If you are a physician, an organization, or other entity or individual engaged in this issue, and you would like to contact us, please send us an email to info@aflds.org. Also, if you're an individual that needs more resources on this issue, you just can go to our webpage, aflds.org, and we'll direct you to some other entities that are active in this area. And I just certainly want to thank you for joining us for part 3 of our 5-part medical mutilation series. Today's episode was about male to female surgery. And the next episode, part 4, is going to examine the financial incentives that are permitting the medical mutilation to just explode. Thank you for joining me on The Gold Report, where we inspire you to be 10% more courageous. Please remember to like, share, and subscribe. We'll see you next time.